class until after. Thanks, Alina. As I was driving here, I was remembering that, in fact, in 1971-72, I taught in the School of Nursing here under Mary Howie before the schools moved into an educational institution. So that's how ancient I am. And when my dad was always telling us some history, we'd say, "Dad, that's ancient history. I don't want to hear that." So anyway, I'm pleased to share with you the ideas about the growth of patient engagement. And as mentioned, I've had a variety of experiences, so I'm going to share with you what I've learned. In 2013, I had 2 surgeries for 2 separate and non-associated cancers. I had a hysterectomy. And when they were screening to see if they would recommend radiation treatment, they found a spot on my lung. Well, sure enough, that was lung cancer. And so I had another surgery for actually neuroendocrine tumor of the lung. In 2015, I was asked if I was interested in becoming a patient advisor at St. Joe's Healthcare. After I'd had my lung surgery 2 years previously there. I had no idea what an advisor was nor what it was involved. So after exploring the role, I accepted it, and here I am. So the way I look at patient engagement is that it is growing. To me, this is the first stage of patient engagement. And this is where you want to end up, where it's a true partnership. So what is patient engagement? Well, it occurs when the patient or caregiver is involved in the planning of healthcare. It takes place at various levels throughout the healthcare system. And really, patients really are engaged, eh? I mean, I think about when I got a call from the gynecologist's office after I'd had what was supposedly a routine D&C on my answering machine when I got home that day. The doctor needs to see you immediately. Please make an appointment, bring a family member. Well, I knew that I was dying for sure, because back when we were teaching the med schools, we had this video that we used to show to med students, and they had 10 days. The doctor was telling this patient, you have 10 days to live, and what happened with that over that 10-day course. So I phoned a girlfriend in tears and explained that, could she come to the appointment with me the next day? So sure enough. But we are engaged, and any parent is certainly engaged as their child goes through the journey in the healthcare system, whether it be through the family doctor, hospitalization, anybody waiting a biopsy, anybody having a colonoscopy and having polyps removed, they're waiting for that report. So they're certainly engaged. Person with sickle cell anemia, they have to be engaged in their illness, and they have to learn a lot about it. A patient with diabetes, anybody with chronic illness. And to me, I've been really pleased at how our particular Hamilton Health team has been able to engage patient advisors in the process. But I'm getting ahead of it. So why should patients be involved? When you have patients involved, you get better outcomes. If they know what the plan is, if they know about their drugs, they're more likely to follow the script or do what you are asking them to do, to follow up with their appointments. Certainly, if they're involved, they often can prevent errors from occurring. So, why am I having this test? I already had it. Why am I getting this drug? Oh, that's a new drug. I haven't seen that before. In fact, when you engage patients, healthcare professionals feel better about the care they provide. There's nothing better than a patient or family member saying, you know, that's been very helpful. I now understand more about my illness. So there's increased satisfaction, which is less stress on the job. Job stress is a big issue for all people in healthcare. And then we have to teach patients how to become more informed and take responsibility and influence, certainly, their care. Some of the other things that research, they respond to incidents. If there's been an unusual occurrence and you involve patients and families and or caregivers, they can often recommend things that may prevent that from reoccurring again. They're an extra set of ears and eyes for you. Now, if we look at the evolution, 1957 is when government started paying for hospital care. Really, when you think about it, as I think about it, my parents had to pay for hospital care before that. And some people were able to get insurances through clubs or organizations, and then the movement right along where 1984, the government passes Canada Health Act, First Minister's Accord on Healthcare Renewal. The LHINs come in play in 2006. And then from 2010, Excellent Care for All Act. All patient advisors really should be familiar with that. And then the establishment of the Ministry of Health Patient and Family Advisory Council, which is no longer that particular body. We were notified that our term of office ended in August of this past year. And Julie Drury is a name you may have heard, and I think we were hoping to have her come today, but she was unable to. She was the first chair, first and maybe the only chair, I'm not exactly sure. And then the People's Healthcare Act, where Ontario health teams are forming now. This is my favorite framework for patient engagement. I find it reasonable. Now, I'll show you the one from Health Quality Ontario on the next slide. But you can look at the levels of engagement right across the board. So the green is the direct care, or right at the ward level, or primary care, where patients receive information and a diagnosis. That would be a consultation engagement. When they're involved, they're asked about their preference for their treatment plan. And a true partnership is when they are actually engaged and are allowed to say, yes, that'll work for me, or no, that won't. And then the red is the organizational level, where the organization, again, is asking about experience. Hospital involves patients as advisors, and right over to patients lead various, or co-lead, I would say, various quality improvements and committees. And then the policy making, which may happen again at the hospital. We were involved in our policy around visiting hours, and we pushed for open visiting hours. So there are some policy issues that you may be involved in, but certainly at the Ontario Health Team, that's where big changes are taking place. And this is Carmen, who has this particular framework, and then the factors influencing engagement. The other one that I don't find as easy, I'm a very visual person. Many of the same words are here, but it's not as simply put for me as the other one. So But Health Quality Ontario have so many resources that you can pick and choose what you find helpful. Another document that's very, very helpful, and I was a part of, is the Declaration of Values. We worked almost 8 or 9 months on developing this as an advisory committee, and then sent it out to various agencies and people for feedback. And at the ministry, there's also a virtual pool which people were able to give feedback on. And so it has these 5 principles, which again, many hospitals have them. What I like about them is that each of them has the behaviors that would show respect and dignity, for example. And you look at number 2 there, we expect healthcare providers will introduce themselves and identify their role in their care. And when I was speaking with another fellow from the Ontario Health Team, he said, "Really? You have to say that?" Yes. Do you know there's about 45 people that enter a patient's room in one day? So that's a lot. And it would be nice if you introduced yourself. "I'm Anne, I'm from housekeeping, I'm here to clean your room." It makes the patient just feel more in control and that people are treating me as a person. Empathy and compassion. And that was interesting. I happened to be a part of the strategic planning group where we went out into the community to the various fairs, and Cactus Festival being one, and the Peach Festival, and asking communities what was important for them when they came into the hospital. And they said compassionate care. That was very important. And when staff were interviewed again, what do you think is the most important part of providing care? Providing compassion. So that was kind of neat to see the blending. That was important for both groups. Accountability. Certainly open and seamless communication. We at St. Joe's are using what initially were called whiteboards. Now we're calling them communication boards, where you know at least the day, who your nurse is, any tests that you are expected to have that day, who the physician is, the most responsible, and your expected date of discharge. So that, and families can write a question on that if they want to. Not easy to keep them up to date, and figuring out who's responsible for that. And we're doing an audit, and often everything's there except the expected date of discharge. And often the caregivers are reluctant to put that on because they say they don't know, but we need to push the healthcare team to at least put that down so that families know what they're working towards, or to, or for, or what. And if it changes, we need to change it. But so that's one of the, I'm not illustrating them all, but transparency. Health records need to be accurate. And personally, I want my access to my health record. I want it on my iPhone. I want the world, eh? And I want it up to date. And I want it in real time. And it's interesting, just recently I had to have an x-ray of my knee. So I picked out a place where, you know, you can get your results back, you know, where you go to a lab, you get your results. So they said, oh yeah, you can get them. So I had my x-ray done. And 2 days later, sure, I get it back, but it's the pictures. Well, I'm not a radiologist, so that's not particularly helpful. So I then had to phone my family doc and ask if I could please have it. Could you please email it? Well, they couldn't email it to me because that's not confidential, so that they could snail mail it to me or I could pick it up. So we need to figure out some of those barriers that are happening, and people are working on it. It's not happening fast enough for me. But it's a tough, tough job. Every hospital has their own system in computers and everything. So the poor people working on it. But again, people, by having their own health record, they've actually been able to correct some mistakes. Again, that and UHN in Toronto have wonderful audits that they've done of charts of patients that have their chart, and it's very, very successful. And people want their pathology reports even now, right, in real time. And we could have a discussion about that if you want to pursue that further. And equity and engagement. And certainly we need more diversity on our PFAC to help us make sure that people aren't being left out because of certain biases that we have, etc. So back to my favorite framework. And so, what is a patient advisor? The important thing from there, it is somebody who has a lived experience, because, you know, sometimes people will say, well, we're all patients at one time or another. Yes, but we want a patient who has been through a lived experience and probably needs a bit of time to get through that lived experience before they're recruited as an advisor, but also somebody who can generalize from their experience and doesn't get stuck in their story, because sometimes they can be so stuck that it's not helpful. So recruiting is important. Any comments? Anyone? You can jump in if you've got any. So this is how I look at how patient engagement starts. You need the culture in the hospital, in the organization, on the ward, in order to have patient engagement. You need the leadership, and the leadership at all levels. And you need the organization or even the society to have patient engagement, because in all honesty, not all societies may want to be engaged as much as what we do in our society. So we do have to individualize, and you get a patient and family advisor. If you have a document to prepare by the stakeholders, by the staff, they love it. However, if you ask the users what they think of it, they kind of say it's a bum steer, right? So it's really important to involve. Or another way of looking at it is patient engagement. We used to do things to you, then we did it for you, then with you, and now it's by you. We're all involved together. Stages of development, and I think this is important. that it takes a while to develop. The Patient and Family Advisory Council at St. Joe's started in 2011, and I joined in 2015, and on the Patient and Family Advisory Council. And another advisor joined at that same time, and I could not figure out how Helen knew so much about the hospital, etc., until I found out that she had been an advisor on the medical ward for a couple of years, and then she had been invited to be a member of the Patient and Family Advisory Council. So she knew a lot more and better and more than I did. So we developed quite an orientation package to help. So you recruit people in the seeds, you give them an orientation. Certainly acronyms have to be shared. It's amazing the language. I'm proud that PFAC we even have our own acronym, PFAC. So, and I just recently got a new one from Health Quality Ontario that will be helpful for the Ontario health teams, because again, once you go out of your system, you have another whole set of acronyms. So you help them, your advisors grow, you help them learn, they get into a budding phase. You develop buddies for them so that if you're recruiting new advisors, that they have somebody that can help them through the process. Eventually you have a whole bunch of advisors, and then you're in a true partnership. I found getting to know the hospital quite a complex system with all the organizations, all the committees, all the working groups. When we were orientating advisors, we would have people come from various departments to explain what they did in the hospital, and we in turn could help them understand how they could involve us as advisors in what they were doing. Kind of the middle phase, I would think of St. Joe's PFAC. In 2015, we had our first event where patient advisors, we had a speaker and patient advisors, and we also had a poster session where staff who had used advisors shared their experience and presented posters. So we kind of had a luncheon and people were able to walk around, and that was very helpful to learn what people were doing in other parts of the hospital and as partnerships. We then, so that was in May, we had another event, and we now have 2 a year. The event that we then had in November was only for advisors, where we gathered the advisors and asked, okay, what's going well? How can we help you? What's not working? What more education do you need? And again, that was very helpful. We did that for a couple of years, and then this past year, we actually invited all healthcare professionals who had any contact with patients to come and sit with us as advisors and say, what can we do better? And we had some role playing and things like that, and that was very, very helpful. Maturity, I think I would say that our PFAC is at a mature level, and some of the things that we're involved in now, our advisors are part of the selection committee for our senior leaders, presidents, VPs, etc. And for that, of course, we had anybody who volunteered for that, we had an educational session for what that would mean and what their involvement would be. So again, they were seasoned advisors, I would say. we're trying to develop a pool of stories. When I was co-chair of the PFAC, I was a member of the board quality committee, and at the opening of their meetings, they have a patient story, but it's not quite what I would like personally. It's it's a staff member presenting perhaps a good case, how they worked hard to make it happen, or areas where they had difficulty, they describe it. It would be nice if patients could come and tell their story, but those are hard, and it's at 8 o'clock in the morning, of course, so it makes it difficult. But we are trying now, as part of our PFAC, to have patient stories. And one of our staff members, we use her for orientation. We now have an hour and a half of time in orientation for all staff once a month to focus on patient-centered care. So Helen tells her, starts the opening part of that session with her story and talks about what went well, what didn't go so well, and how you as staff can make a difference in a patient's life. And that's been very helpful. But that has taken us quite a while to develop that. So you may want to think about your goals. So as a result, we developed a whole booklet for patient and family advisors. And it really does show all the charts of the organization, a little bit of the history, what an advisor is, how that's different from an advocate, acronyms, the various work groups that people are on, because there can be groups that continue on. We have our communication committee continues on, and we plan the events. The signage, which is interesting when I tried to get into this building, how a patient or a visitor sees signage, and we've had some interesting discussions at St. Joe's on how to make it patient and family friendly. But it just, I'd be happy to share whatever you might find helpful from that. Then again, as we matured as a patient and family advisory council, we now have kind of a work plan for the whole year. And our meetings are kind of set up in 3 sessions. And by committee updates, that would be any advisor that's working on a committee, could they please report back something new from the last time? And we're always checking out with them, are things going okay, or do you need help, or whatever. I've just become a member of the Quality Improvement Council on Medicine. I had not been to a department quality council, so I've been to my first meeting. But when you see quality councils, we're expected to comment on what's being presented. In September, we reviewed our terms of reference. We had people who, since 2011, had still been on our PFAC committee. They didn't particularly want to come off. And up until this point, we didn't have a lot of people that were knocking at the door, but we went on quite a great recruitment. So we needed to ask them to step down, with the understanding that just because you're not on the PFAC doesn't mean that you wouldn't be an advisor in the hospital. And in fact, some of their seasoned experience makes them very eligible for some of the harder tasks that may be hard for a new advisor to learn. So I found this very helpful as a chair. You knew kind of what your next meeting would be about, etc. And so the challenges, and I understand you've already had somebody talk about change, and it's very important that you have the leadership support, the culture changing in education. And it's interesting, who wants change? I wonder how many of us, well, I think we all want change. It's boring otherwise, right? And then who wants to change? And then, of course, everybody puts their head down. And when we're in orientation and we have a role playing and we are trying to pass out roles, who wants to be? They've all got their heads down. We know that. And then who wants to lead the change? All of a sudden the room empties. So it's not easy, but it's the way of the world. I would also say at St. Joe's, we had great support from our leaders and directors and VPs, but not so much with our managers. That was the toughest group to help learn about patient and family engagement. So we've made sure that we have one of our advisors on their management meeting that meets regularly, and we have a manager now that comes to our PFAC meeting, and I think that has been somewhat helpful. And in fact, our challenge to the manager that comes to the meeting is to ask one of their peers to present a patient story. So they have a little bit of a task to do. But that has certainly helped, and I would encourage you not to be too ambitious. As I say, our PFAC started in 2011, and I would say in the last couple of years it's reached maturity, but it's been a lot of growth, a lot of education, a lot of work, and well worth it though. Our accreditation took place in May, and we asked that we have an advisor as part of the accreditation team, and they were pleased with our patient engagement, so that was very rewarding. So here's a couple of resources, and that's an HQO thing. And there's the end. Giving you my words of wisdom or whatever.
Are there any questions for Bernice?
Bernice, how did you deal with the issue of diversity?
Of diversity? We're still dealing with it, actually. Just recently, we have 2 members of our youth advisory council that come from the clinic that looks after youth with mental health or addiction problems. That's one of our strategic plans because it's a big issue. Even with the, and I can never say it all right, the LBQ, the signage on the washrooms and etc. That's all being looked at. The last meeting of strategic planning, we were saying we kind of believe it, but really it's not evident if somebody came into the hospital. So we have to bring it forward and make sure that we're practicing it. And so we're in development, I would say.
I think there was another question over there. Yeah.
Can you give an example of, you talked about someone coming forward or deciding or recruited to be a PFA, and you mentioned they have their experience and then before they might want to get involved, they're stuck. Can you give an example of what you mean by
yes,
that?
We have, okay. Let me try and make it anonymous. Somebody who has experienced suicide within their family, that every meeting that comes up about suicide, and it even gets diverted from what we may be chatting about, and we know that that person is still hurting, but hasn't been able to generalize it. So that would be one example.
So it's too raw still.
Yeah, but it's been years since this person went through that. So I think you have to be careful. Anybody that's even experienced a death, depends their phase of grieving, if they're able to deal with that.
Oh, great. Any other questions? Yes, Joy.
You talked about culture on the wards.
Yes.
Are you meaning getting the wards to understand what the PFAs are?
How to use them? Yes.
Yeah.
And
How would you get that?
one example that I think is a very good one, we had a fellow with chronic obstructive pulmonary disease, and he was on the ward where patients are looked at. They were looking at a care path or care plan or whatever people are calling it these days, and they were going down one way, and he said, wait a minute, unless you deal with their anxiety for the chronic obstructive pulmonary disease patients, you're not going to go anywhere. So all of a sudden people realized, oh, by having him involved, that made a difference. It's slow, and I think you gradually win people over by, rather than bringing the brochure and saying, what do you think about it? Advisors are right there developing it. And I think certainly in the strategic plan, it was interesting because they had what we call ambassadors who are going to help the staff learn about the strategic plan. But people had put up certain things from HR, for example, that they wanted staff to experience joy in their life. Because again, that's what the literature said. Staff said, no. I cannot relate to that joy, because if I've had a patient die today, I don't feel joyful. I may feel satisfied, but it's not joy. So it's just how people perceive it, and breaking down barriers so people can understand. Did I answer the question?
Yeah, no, you did.
I think it's just kind of, you can get a manager who's willing to have an advisor on the ward. We're thinking about maybe using advisors to just go around and see if the communication boards are being filled in.
You mentioned having a manager come to the PFA meetings.
Yes.
Different ones every month?
No, they kind of have a term.
Okay.
Yes.
All right. One or two different.
Yeah, that seems to have worked well.
Okay. All right.
Yeah.
Your terms of reference, is there a limit of like 2 years or?
There is once renewable, but you see, when we didn't have all sorts of people to replace, we didn't. But you have, like, I need to come off next year. I'm stale, so I need to
So you think that's
have
really
new people.
important?
But it's hard, when you think about the commitment. It's a fair bit. We ask for, I think it's a minimum of 4 hours a month, kind of. But when, like, our PFAC is 2 hours, so.
Right, yeah, so right there.
Yeah,
But even if they're not, they can still be involved, like you said, on bigger projects.
yeah,
That's
or
more-
short-term projects too. There
Yeah.
could be short-term projects that, they have a beginning and an end, which is really
Yeah.
nice. It's not a lifetime sentence. Yes.
Bernice, thanks for your presentation. With the evolution that you guys had at St. Joe's, with going from, probably similar to just having a committee and then formalizing the PFAC and then actually breaking back off into holding a PFAC with a smaller group of individuals, moving to still having a committee on the outside. what were some of the challenges that you guys had to face as you started to identify who would remain on feedback versus who would transition into just projects? And any sort of recommendations on what you would do differently?
I think it's going to be easy now because we're going to stick to our terms of reference. We're going to make sure that we have enough of a pool that people can move in. But like in some ways, it's rather ironic. People didn't want to move off because they really, really enjoyed and felt they were making a difference. But we wanted to have more diversity and a fresh look. So, I remember one gal saying, but how will I know what's going on? Well, we post our minutes on the website. So it's just the communication, and because they've already been asked to do some things like interview senior staff because they've been through the orientation, we've been asked them to do that. So you don't want to lose people that have already, yeah. Oh, that's the other thing too. We actually developed an award, 2 awards, one for an advisor, and they were presented at one of our events, and one for a group. And there was criteria. And the other thing, we have criteria for people to fill in once a year if you're on a committee or a work group, and that's from the advisor perspective. What went well? Did you feel listened to? Were you involved, etc.? And then from the people that lead the group, did the advisor come prepared? Did they participate, etc.? So that's been helpful because then we get it and we can figure out it worked or it didn't work and where we need to improve things. Yeah.
Do you have opportunities to meet with the broader people, like the patient family advisors who are not on feedback, or you can do check-ins?
We do, and we certainly have that event once a year where all the advisors come from all the different sites, West 5th and Urgent Care and Charlton, and have the event just for advisors, although we've now opened it up, as I say, too. But we always, through the quality department is where we get our support, and they check in periodically with the advisors on how it's going, because they keep track of all the different projects and work groups that are happening.
Who does that?
Our quality, we have one person that supports us through that. And then when I was co-chair, I was always making sure whenever Jessica sent out for volunteers, I would always check who's offered to be that, just to make sure that they had been filled, that position had been filled or request had been filled.
Do you have the participation on the medical advisory committee with advice?
No, we don't.
You know?
No.
And do you do an annual report, or do a report at the annual meeting?
I prepared a report for 2017 just because people, they had done a bit of a one, but I went through every single minute and put through what they said they were going to work on and what they had accomplished. So I did that right up until 2017.
Okay.
Because it was interesting, you know, the thing, you probably wouldn't be surprised that right from the very start is discharge planning and communication are the big issues.
Yeah.
I don't think you can go to any hospital, but that's an issue. So it's getting better.
Slowly.
And now we're not even calling it, certainly from the healthcare thing, we're calling it transitions, because you may be discharging them, but in fact they're still in the healthcare system, so they're transitions. So it's again just interested in the language we use.
I just had a question around the Hamilton Health team and being the co-chair and the patient family advisor. Has that, do you think, shifted the culture of some of the conversations that happen at the Ontario Health team level
Do you think the conversation has been noticeably different than if it didn't have a patient advisor involved?
I do. And our primary care physician who led the workshops. So I'll just backtrack a little bit. John Fleming is the advisor from Hamilton Health Sciences, and I was from St. Joe's, and we were invited to a meeting April 16th, I think, something like that. And we go into the room, and there's about 40 different people there from agencies, etc. And at the end of the meeting, they asked John and I if we would co-chair the meeting. We kind of had warning before we went. They said, we'd like you to be co-chair. Don't worry, there'll be lots of help. And that's it. So we get to the meeting, they ask us, and John and I look at each other, sure. We get home that night and we said, what have we got ourselves into? Anyway, so we were involved until we submitted the assessment phase of the proposal in May. And then we assumed that we would hope we would be one of the early adopters. So we continued on meetings and planning. And what I did, I asked people who were at the table if they had advisors that they would suggest that could be involved. We asked the LIN, we asked the hospitals, and we asked the societies. So we were able to get 15 advisors. We then sent out letters and invited them if they would like to become a member of the Hamilton Health team in putting the proposal together. And that was really encouraging to have that many, because the various work groups, we were able to divvy them up depending on their interest. They were asked what their interests were. It was governance, home care, digital health, mental health adult, mental health children, and frail, complex elderly. And so those were the groups that would be working on this proposal. There were 4 workshops that everybody attended, the advisors, for 3 hours, from 4 until 7. And we sent out an evaluation afterwards. We haven't got all the evaluations back, but certainly the primary care physician who led the workshop said, absolutely, it was important to have advisors at the table. If we have the same people at the table, we're not going to change the discussion. And she felt that really the advisors had made a difference. After the very first meeting, we had an email back from somebody that said, that was amazing to have an advisor there to talk about the mental health issues and how we can make a difference. So that was really encouraging. And we've had positive feedback from the advisors. Some of the issues, and they felt they would have liked to have had a debrief after the meetings. By 7 o'clock at night, I am done, believe me. But anyway, we'll have to build that in as we go on. And one person felt that they weren't listened to and it went so fast. And I can understand that, because again, with time limits and you're trying to put something together, and there's been some background discussions that they haven't been posse to or party to or whatever. So it has changed the conversation for sure. Yeah. Wish you, yeah.
The pools, you talked about a pool of stories.
Yes.
Because the patient stories drive the PFAs. So are they just like in a written form? How do you
well,
present?
my ideal would, yes, I asked a gal over the summer if she would be willing to tell her story as a caregiver. Her husband had a kidney transplant and she put it together. Now, we'll be sitting down with her because, in fact, there's about 3 different parts of the story that we could really use in different parts. Some of that would be in person, but I think a lot of people are uncomfortable doing it in person, so we video it and then use it. Helen, who does it at our orientation session, she's come in person all the time, but in fact, we videotaped her in case she's unable to come. There's nothing like hearing it right from the patient that makes a difference.